The anatomy of the shoulder joint complex allows for a tremendous range of motion. However, the high degree of mobility requires some compromise in stability, which in return increases the vulnerability of the shoulder joint to injury, particularly in dramatic overhead athletic activity. The shoulder girdle complex is composed of three bones: the scapula, the clavicle, and the humerus. These make up the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic joint. Dynamic movement and stabilization of the shoulder complex require integrated function of all four articulations if normal motion is to occur. The glenohumeral joint is a ball and socket synovial joint in which the round head of the humerus articulates with the shallow glenoid cavity of the scapula. The muscles of the rotator cuff, which consist of the subscapularis, the infraspinatus, the supraspinatus, and the teres minor, along with the long head of the biceps, function to provide dynamic stabilization to control the position and prevent axis displacement or translation of the humeral head relative to the position of the glenoid. Stabilization of the humeral head occurs through contraction of the rotator cuff muscles. Supraspinatus originates on the supraspinatus fossa of the scapula. It inserts on the greater tubercle of the humerus and helps the deltoid abduct the shoulder. It is one of the only muscles in the rotator cuff that does not do internal-external rotation. Infraspinatus and teres minor both abduct the shoulder and externally rotate the shoulder. The infraspinatus originates on the infraspinatus of the scapula and inserts on the greater tubercle of the humerus. Meanwhile, the teres minor originates on the lateral border of the scapula and inserts on the greater tubercle of the humerus. The subscapularis is the only muscle in the rotator cuff that medially rotates the shoulder. It originates on the subscapularis fossa of the scapula and inserts on the lesser tubercle of the humerus.
The pulley exercise is an active assistive exercise used to regain shoulder flexion. You should instruct the patient to pull with their good arm and allow the bad arm to go along for the ride. Scapula isometrics are used for increasing protraction and retraction and for shoulder stabilization. You should instruct the patient to squeeze their shoulder blades back while keeping their elbows at their side. Codman's pendulum exercises are used as a general stretch when motion above 90 is limited. You should instruct the patient to lay prone on the table and move his or her hand in a circular motion and reversing directions occasionally.
For the standing T-bar exercise, you want to instruct the patient to use their good arm to help push out the bad arm away from their body. This is a range of motion exercise that will increase abduction. Optimally, you'd want the patient to achieve 180 degrees of abduction when they are finished with physical therapy. For the supine T-bar exercise, you want to instruct the patient to lay supine with the T-bar. Have them keep their elbow of their bad arm by their side and pushing their hand away from their body with the T-bar. This is a range of motion exercise that will help increase external rotation. Table push-ups are something that can be implemented in phase 2 to help begin some strengthening. You want to instruct the patient to begin with their hands on the table and their feet away from the table in a push-up position. You want to make sure that their body stays straight and that their elbows are tucked in by their side and they are doing a proper push-up.
Band follow-throughs. First, tie TheraBand to leg table. Make sure patient is in a split throwing stance, and then instruct the patient to grab the band and pull from opposite hip into flexion and external rotation. At optimal external rotation, instruct the patient to bring the band back to the opposite hip in a controlled manner, in which causes an eccentric exercise for the shoulder. Rhythmic stabilization with the Swiss ball. With athlete in a push-up position on the ball, feet planted and hands stabilized on the Swiss ball, have patient hold position while clinician pounds on the ball to create motion and force the rotator cuff muscles to fire and facilitate isometric contraction and collectively maintain dynamic stability in the shoulder. Athletes should be standing in front of the table or supine on the table with their arm abducted to 90 degrees, and the clinician should drop the ball into the athlete's hand, creating an overload in lateral rotation that forces the athlete to dynamically stabilize in that position while the athlete works on their internal rotation and range of motion exercises. To progress this exercise, you would simply add weight to the object in which you were dropping into the athlete's hands for this exercise.
A return to play interval throwing program is designed to help an athlete regain strength in their shoulder or rotator cuff, work their cervical spine and muscles that affect the glenohumeral joint, as well as exercises that work the elbow, hand, and wrist. For an overhead throwing athlete, the throwing progression is one of the final criteria for full return to play. It is progressive in distance, repetition, and duration intensity. Complete success in each level is imperative for progression to the next level. The distance progression starts at 45 feet and ranges up to 180 feet. In each phase, there are 2 steps that must be completed before the athlete can move back to the next 30 feet. In each step, you begin with a warm-up of throwing. Then for 45 feet of distance, an athlete can throw 25 throws. Then rest 15 minutes. Athlete then throws another 25 throws from 45 feet, and rest begins at step 2. Step 2 consists of the same 25 throw progression, but instead with 2 10-minute rests in between each set of 25 throws. In order to progress from step 1 to step 2 and so on, the athlete must successfully complete 50 throws.